Inguinal hernias of the third kind, challenging 500 years of surgical doctrine. The definition of both indirect and direct hernias is well known and described by Doctors Nyhus and Condon, with direct hernias going through the weak area within Hasselbalch's triangle. This is a laparoscopic view of a left inguinal hernia with defects at the transversalis fascial sling and another defect medially within Hasselbalch's triangle. Here is the transversalis fascial sling accepting the spermatic cord, representing the true deep inguinal ring. Medially, however, there is a left direct hernia defect passing through Hasselbalch's triangle. Laparoscopically, some patients have three defects seen clearly: an indirect hernia, a direct hernia, and a third defect lying between the two. So what about this third defect? In this patient, there are two defects lying lateral to the inferior epigastric vessels. The defect here is medial to the deep ring, representing a third hernia which passes through the canal out through the external ring. This demarcates the true deep ring itself. The same patient has a direct hernia on the right and an indirect hernia representing a classic pantaloon hernia straddling the inferior epigastric vessels. In this patient, there is a large defect lying outside the deep ring, yet lateral to the inferior epigastric vessels. This is the third type of inguinal hernia. Here is Hasselbalch's triangle, which remains intact. The defect is lateral to the vessels, but does not penetrate the deep ring through the transversalis fascial sling. Classic teaching is that there is no obvious recess between the deep ring and the vessels or Hasselbalch's triangle. However, some patients do have a widening gap between the vessels and the deep ring. Here is the transversalis fascial sling, and this is the recess lying lateral to the vessels. The concept of indirect and direct hernias dates back many years, and Caspar Strohmeyer in 1559 distinguished between the two. There are many and varied classifications of inguinal hernias, most recently with the European hernia classification, but none question the definition of a direct hernia and of course do not mention a third hernia. So how do we explain the presence of a third hernia? Perhaps direct hernias occur anywhere within the weak area. This demonstrates the mobility of the inferior epigastric vessels, with direct hernias appearing medial or even lateral to the vessels. Perhaps we have placed too much emphasis on the inferior epigastric vessels as popularized by Hasselbalch. In his original definition, of course, there were two defects medial to the vessels. It was Fouchot who described the weak area as being the myopectineal orifice through which all hernias could appear. It was Caspar Strohmeyer in 1559 who distinguished between the two because he used to amputate the testis in indirect hernias and leave the testis alone in direct hernias. Perhaps, therefore, we should question the definition of a direct hernia, and I would like to ask my esteemed colleagues whether we should reconsider defining a direct hernia which may or may not include Hasselbalch's triangle. To paraphrase Sir Astley Cooper in this well-known quotation, we of course require accurate anatomical knowledge to perform safe surgery. I am grateful to Dr. John Garvey for confirming the presence of a third hernia with the sac lying lateral to the vessels at open surgery and the sac not penetrating the deep ring. There are therefore three types of inguinal hernias, and perhaps we should have a new definition of a direct hernia. The indirect hernia, of course, will pass through the diverging limbs of the transversalis fascial sling, and the new definition of a direct hernia is one that passes either side of the vessels and can occur anywhere within the weak area, but does not enter the true deep ring. Thank you.